Good to go, Shannon.
Good to go.
All right. Well, good morning, everyone, and thank you for attending our Grand Rounds lecture this morning. My name is Kelly Fox, and I am one of the current Chief Cardiology Fellows here at VCU. This morning, I am honored to introduce to you our speaker, Dr. Sriram Sriperumbuduri. Dr. Sri, as he is known, comes to VCU with previous training in medicine and nephrology from India, Canada, and the United States. He has received additional training in hypertension and home dialysis. He has also received certification from the American Hypertension Association. Dr. Sri joined VCU as an assistant professor of medicine and nephrology in October 2023. His expertise involves managing patients with a wide spectrum of kidney disease, including AKI, CKD, and kidney stones, along with electrolyte and acid-base disorders. He is adept in managing different modalities of dialysis, including HD, CRRT, and PD. He is also proficient in management of difficult-to-treat hypertension and evaluation of patients for secondary causes of high blood pressure. We are grateful for Dr. Sri's expertise on his topic today and look forward to learning from him. At the end of the lecture, we will leave time for questions, so please submit questions via the chat function on Zoom as they arise during the talk. We are also pleased to offer both CME and MOC credit for today's Grand Rounds. To claim credit for today's session, please text the code shown at the beginning and end of the presentation to the number on the screen. And for questions or how to log into your Cloud CME account, please visit vcu.cloud-cme.com or contact Shannon Winston. Dr. Sri, I will turn it over to you.
Good morning to all, and thanks, Kelly, for taking the effort to pronounce my last name. And thanks to Dr. Handley for giving me a chance to present in this cardiology grand rounds. Very excited this morning. So today I'll be talking about the association between primary hyperaldosteronism and cardiovascular disease. And the objectives of my talk are three. So one is defining this condition and describing its key clinical features, describe the association of primary aldosteronism or primary hyperaldosteronism with cardiovascular disease, and to describe the screening tests for primary aldosteronism. At the outset, I do not have any conflicts of interest related to this topic. I'll start with a case presentation, which involves a 58-year-old male with a diagnosis of hypertension and hypokalemia. He was diagnosed with hypertension at the age of 38 years and had 3 admissions so far for uncontrolled hypertension and a low potassium. Echocardiogram confirmed left ventricular hypertrophy. His current medications include lisinopril of 40 milligrams, nifedipine extended release 60 milligrams, and carvedilol 50 milligrams. His serum potassium in the previous labs was ranging anywhere between 3.1 to 3.4, and serum bicarb was ranging anywhere between 24 to 30. So what are the next steps in management of this patient? So we'll get to this at the end of this presentation, but I'll start the talk with a physiology of aldosterone production, and I'll keep it brief. So the most important stimuli for the synthesis or production of aldosterone are two. So one is hypovolemia, which increases the production of aldosterone and is a renin-dependent activation of aldosterone production via the angiotensin II pathway. And then the second big stimulus is hyperkalemia, wherein we have a renin-independent aldosterone production. So under all physiological conditions, these two are the major stimuli for production of aldosterone in the body. What happens in a dysregulated aldosterone physiology? I'll be using this term dysregulated interchangeably with primary aldosteronism because the mechanism of aldosterone production in primary aldo is autonomous or it is dysregulated. So it starts with excess production of aldosterone from the adrenal cortex. Something stimulates the cortex. It could be an adenoma or excess proliferation of cells. This aldosterone acts on the melanocorticoid receptor, which is present in the principal cells of the distal part of the collecting duct of a nephron, which in turn stimulates reabsorption of sodium through the ENaC channel. And to maintain a electrical neutrality, there will be secretion of potassium and protons from the cells. So the net effect of this is there will be increased reabsorption of sodium along with water plus loss of potassium and protons. So there will be increased intravascular volume, increase in blood pressure, hypokalemia, and metabolic alkalosis. And this expansion of intravascular volume will lead to inhibition of renin and angiotensin system. So the key point here to understand is in any dysregulated aldosterone physiology, and in all cases of primary aldosteronism, this happens, there is a renin and a potassium independent aldosterone production. So the key word is being independent from renin, and this is what we use when we try to screen these patients for excess aldosterone production. So what is primary hyperaldo or primary aldo? The classic clinical presentation is always described as someone with resistant hypertension, spontaneous hypokalemia, and metabolic alkalosis. What are the cardinal features of this? So there are three. So the first one is there is a suppression of a baseline renin secretion. So the renin levels are almost always low in these patients. There is an inability to stimulate renin with the usual stimuli, and the usual stimuli being whenever there is any restriction of sodium, whenever the patient gets into an upright posture or use of medications, which like RAS inhibitors, they may not be able to stimulate the renin to a higher level in patients with primary hyperaldo. One point to understand is this is a very relative concept, which really depends on how severe the primary hyperaldo is. In more severe cases, we see much lower renin levels, so a greater renin suppression because of a higher aldo, and it will be difficult to stimulate the renin or increase the renin no matter what drug the patient is on. Whereas in milder cases, you can unsuppress the renin with any of the stimuli that I was talking about, especially with sodium restriction and with drugs. And the third one is an inappropriate and non-suppressible aldosterone production, which is the basis of the confirmatory test that we use to diagnose this condition. So the other important thing is to understand that hypertension and hypokalemia are not fundamental characteristics of primary aldo. If anything, they are dependent features. And what do they depend on? So whenever there is excess reabsorption of sodium and fluid in primary aldo, there is expansion of intravascular volume. As long as the vascular system is compliant and is able to accommodate the excess volume, the person may not develop any hypertension or may develop a mild hypertension. Only if the expansion is significant or if the vascular system is not compliant, as happens with aging, there is a higher chance of developing more severe degrees of hypertension. Same thing with hypokalemia. There is loss of potassium, but what matters is as long as the person is able to maintain an adequate intake of potassium, their potassium levels can stay within normal limits. And it also explains why these patients are at higher risk of having a thiazide-induced hypokalemia, because there is already loss of potassium because of the aldo, and then you are giving them thiazides, which just increases the caliuresis, and the person may not be able to maintain a normal potassium even with adequate intake. The so-called classic or overt primary aldo, which is described in textbooks and which we all learn in medical school about all the classical features that I was talking about, is something which typically happens in those with an aldosterone-producing adenoma and a bilateral adrenal hyperplasia. There are various criteria to describe this. Some of them being having a 24-hour urine aldo which is more than 12 with a sodium of more than 200, or having a 24-hour urine aldo of more than 10, sodium of more than 200, and a ratio of more than 30, and even a aldosterone-renin ratio of more than 20 with a plasma aldosterone of more than 15. But the common feature is all this should be accompanied with a renin which is below the limits of detection as described in standard guidelines. But if we look at these milder forms of primary aldo, we have evidence at this point to show that there are these aldosterone-producing cell clusters which happen because of somatic mutations in the ion channels. So presence of these aldosterone-producing cell clusters will also cause a dysregulated or an autonomous aldosterone production, which may or may not present with all the classic or the overt features of primary aldo. And the important thing is because many of them have like a milder presentation, they have a less suppressed renin, and meaning there is a greater ability to stimulate the renin when they are sodium restricted or when they're on medications like diuretics or the RAS inhibitors. And they can test negative on the standard confirmatory test because the standard confirmatory tests were originally designed to make a diagnosis of the more classic patients, the more classic cases of primary aldosteronism. So, because of this evolving concept about this mild forms of primary aldosteronism, there was a landmark study which was published some time ago, looking at the unrecognized prevalence of primary aldo in the community. And this was based on data from 4 centers across US, where they estimated the prevalence of primary aldo using a 24-hour urine aldosterone as the criteria. The cutoff is more than 12 micrograms. Suppressed renin activity is defined as a plasma renin activity or a PRA of less than 1 microgram per liter per hour in a seated position or less than half microgram per liter per hour in a supine position, because when someone is supine, we expect the renin levels to go down. So they have a lower cutoff for supine. All the patients except those in the group of resistant hypertension had salt loading, meaning their 24-hour urine sodium has to be at least 190 millimoles. And they looked at the distribution of this renin-independent aldosterone production among the entire spectrum of hypertension, ranging from normotension, stage 1, stage 2, and the resistant hypertension. And what they have found is actually phenomenal as you look at this graph. So here we have the distribution of the subjects on the x-axis and the 24-hour urine aldo on the y-axis. And we see the 4 groups based on the degree of blood pressure. And the line represents the cutoff which they used in the study at 12 micrograms of aldosterone being excreted over 24 hours. What it shows is, as the severity of hypertension increases, we see an increasing prevalence of the more classic overt primary aldosteronism. But the important point is really to focus on the left half of the graph, where even in those with normotension or stage 1 hypertension, there is a prevalence of primary aldo, which frequently goes unrecognized because we usually don't screen them. And the more important thing is, this is really the cutoff for more classic overt aldo. But there is all this distribution of higher aldo levels, even in the face of a suppressed renin. So all this likely represents the milder forms of primary aldo, which happens even in people with normal blood pressures and stage 1 and stage 2 hypertension. And if you look at the prevalence rates of this high aldo across the various groups after adjusting for other baseline parameters, using a conventional definition of 12 micrograms in 24 hours, the prevalence rates keep increasing as the severity of hypertension increases, as it showed in the previous slide. But even if you use a more liberal cutoff of 10, we see that the prevalence rates are much higher, almost 20% in those with normal blood pressures. So why do we need to know all this? Because there is certainly a higher incidence of cardiovascular disease which can happen as part of primary aldosteronism. This graph kind of describes all the salient features of all the mechanisms by which hyperaldo can cause cardiovascular disease. I know this is very basic for this particular group, but I'll just go through this very quickly for the sake of students or residents who are part of this crowd. So hyperaldo leads to a volume expansion. So there is increased preload, increased LV stroke work, which in turn leads to changes in LV and LA, including hypertrophy, fibrosis of LV, electrical remodeling, diastolic dysfunction, which can in turn lead to dilatation of left atrium and can predispose to atrial fibrillation. Similarly, volume expansion also leads to increase in the blood pressure. Hyperaldo also causes hypokalemia, which increases the risk of atrial fibrillation. Increase in the blood pressure will increase the LV work, which increases the myocardial oxygen demand, increasing the susceptibility to ischemia. And hyperaldo through oxidative stress and inflammation can lead to endothelial dysfunction, vascular remodeling, leading to an increase in the afterload, which in turn can increase blood pressure. Plus, the arterial stiffening will also have an effect on the LV function, leading to impaired coronary perfusion and increasing the chance of myocardial ischemia and heart failure. Sorry. So this study described the changes in cardiac structure and function across the spectrum of aldosteronism, and this is based on the data from the ERIC study, which is atherosclerosis risk and community study, where they have selected about 4,547 participants without a prevalent heart failure. They have estimated their plasma aldosterone levels and plasma renin activity. Suppressed PRA was defined as a level of less than half nanogram per ml per hour. And they looked at these following outcomes, including hospitalization due to heart failure, combined heart failure and all-cause mortality, the composite of heart failure, death, MI, and stroke, incident atrial fibrillation, and they looked at the various echocardiographic parameters. So if you look at the baseline characters of this group, they have divided the patients. So they have divided the stable one into 3 columns. So this is the total study population. This one has a suppressed PRA, which is less than 0.5. And there is a unsuppressed PRA, which they have defined as more than 0.5. Not sure why they have used the 0.5 as the cutoff. Maybe they had a samples which were taken in a supine position, but I couldn't find the data in the article. So if you compare these 3 groups, the mean age was significantly higher in the group which were renin suppressed. They had significantly less males in the renin suppressed group. The distribution of African Americans was about 18%, with slightly more African Americans in the renin suppressed group, which is how the common distribution happens. The systolic and diastolic blood pressures were significantly higher in the renin suppressed group. Relatively less number of patients in the renin suppressed group were on antihypertensives when compared to the unsuppressed group. The median aldosterone was about 4.7 in the renin suppressed group versus 5.4 in the renin non-suppressed group. So in this table, they looked at they compared the various echocardiographic parameters related to LV and diastolic dysfunction, and compared between these 2 groups of renin, the low renin and the high renin groups. And when they looked at the adjusted analysis, as we get to the last, the rightmost column, here they have adjusted for all the basic parameters and also adjusted for the baseline blood pressure plus the use of antihypertensives. So even after adjusting for all this analysis, there is a significantly higher left ventricular mass index and significantly higher left ventricular end diastolic volume and end systolic volume in the renin suppressed group. Similarly, with regards to the parameters of diastolic function, there is a significantly higher left atrial volume index and E by A ratios, which show increased chance of having a diastolic dysfunction in the renin suppressed group. In this graph, they have plotted the plasma aldosterone on the x-axis and then compared with a couple of echocardiographic parameters. One of them in the A, they have left ventricular mass index, and they have plotted 2 curves. So the black one represents the renin suppressed group and the blue represents the renin unsuppressed group. And as far as the LV mass index is concerned, what they have found is in the renin suppressed group, as the plasma aldosterone level increases, there is a increase in the left ventricular mass index, showing an interaction between a low renin and a plasma aldosterone with regards to the LV mass index. With regards to the left atrial volume index, it is certainly higher in the group which was renin suppressed, but there is no interaction with the plasma aldosterone level. And if you look at the same graphs where they have plotted the aldosterone-renin ratios, and when they looked at the LV mass index, with increase in the aldosterone-renin ratio, there is an increase in the LV mass index. A similar relation was seen between a higher aldosterone to renin ratio and a higher left atrial volume index in this study. About 11.6% of these subjects, so about 529 of them, had a positive screen for primary aldo, where the ratio, and they defined the positive screen as having a aldosterone to renin ratio of at least 20 and a PRA which is less than 0.5. And these subjects had a higher blood pressure, had a greater left ventricular mass, and a larger LV and left atrial volumes. And when they looked at subjects without hypertension, but who had a suppressed renin and higher aldosterone concentrations, they have found that they still had a greater LV mass index. They had a more impaired global longitudinal strain and impaired diastolic parameters. And in this table, they compared the outcomes which I described in the initial slide, including the hospitalization due to heart failure, all-cause mortality, the MACE events, and atrial fibrillation, against the tertiles of aldosterone, so increasing aldosterone concentrations. In the adjusted analysis, they could not show any significant association between these outcomes based on the plasma aldosterone levels. But with respect to atrial fibrillation, there was a increased hazard of developing AFib in the highest tertiary group of plasma aldosterone, even in the adjusted analysis. What about the effects on cardiovascular health in patients with subclinical primary aldo? Just before I start this, one important take-home point from the previous study is that there is an independent effect of aldosterone on the cardiovascular health, which is not dependent on the degree of blood pressure, on the severity of hypertension, or the degree of blood pressure control. Even if the hypertension itself is well controlled, presence of circulating aldosterone has a bad effect on the cardiovascular system, as shown by the abnormal parameters in the previous study. So in this study, they looked at the cardiovascular health in patients with subclinical primary aldo. And for this, they have included a population-based cohort from the province of Quebec in Canada. And they have selected about 1,284 subjects in this final cohort because all these subjects have a cardiac MRI data at 5 to 7 years post-enrollment with the study. All the subjects had blood samples which were drawn at baseline in a seated position. And the outcomes that they looked at in the study include arterial stiffness using the parameters of central blood pressure and pulse wave velocity. And they looked at adverse cardiac remodeling based on the MRI data, which includes the indexed maximum left atrial volume, left ventricular myocardial index, left ventricular, and the left ventricular remodeling index, and left ventricular hypertrophy. They also looked at incident hypertension at 5 to 7 years post-enrollment. The only thing is, when they looked at incident hypertension, they based the definition of hypertension based on readings, based on standardized blood pressure monitoring in a single visit, as against doing it in a couple of visits, as is described in all the standard guidelines. And all the analysis was adjusted for baseline brachial blood pressures. If you look at the baseline characteristics of this group, their mean age is about 54 plus or minus 8 years. About 49% are females. 94% were whites. The baseline cardiovascular disease was about 2%, about 6% were diabetics, and 43% had hypertension. Their median plasma aldosterone is about 210, which converts to, in our units, about 7.6. Direct renin concentration is about 8 nanograms per liter, which converts to a plasma renin activity of about 1.5. And the aldosterone to renin ratio is about 27. And in this graph, they have when they have done a multivariable like a multivariable adjusted linear regression, and tried to compare these aldosterone-renin and the aldosterone-renin ratio against the parameters for arterial stiffness, they have found a significant association between a higher aldosterone to renin ratio with both a higher central systolic blood pressure and a higher pulse wave velocity. A similar association was seen with higher aldosterone levels with both these parameters. There was a significant association between a lower renin levels and a higher central systolic blood pressure. And when they repeated the same study using subjects only with normotension at baseline, they have still found a significant association between higher aldosterone to renin ratios with both a higher central systolic blood pressure and a higher pulse wave velocity. Association of higher aldo with higher pulse wave velocity and a lower renin with both these parameters. And when they looked at the various parameters of cardiac remodeling using the MRI, they have found a significant association of higher aldosterone to renin ratio with all these three parameters, including the indexed maximum left atrial volume, higher left ventricular mass index, and a higher left ventricular remodeling index. A significant association of higher plasma aldosterone with increased left ventricular mass index and increased left ventricular remodeling index. And for the renin, the significance was found between a lower renin and only with the indexed maximum left atrial volume. A similar association was found in subjects with normal blood pressure, where the significance was found for higher ratios with an increased left ventricular mass index and increased left ventricular remodeling index, and a higher aldo with the same cardiac parameters. And for the left ventricular hypertrophy, there is a higher odds of LVH with increased aldosterone to renin ratio. And the same thing was shown in the subjects with normal blood pressure. As far as the incident hypertension is concerned, the incidence was higher in the odds of having an incident hypertension is significantly higher in the group with higher aldosterone to renin ratio. The important take-home point from this study is that these represent a group of people whom we don't even suspect having a primary aldosteronism or having any dysregulated aldosterone production, and they hardly get screened. But even in those, when we have this dysregulated aldosterone production, it can lead to adverse cardiac outcomes and even a higher risk of having an incident hypertension, which raises the question about if there is a role for a more earlier implementation of screening for this dysregulated aldosterone in subjects even with milder degrees of hypertension. And this is probably too much of hypothesis generating, but maybe there is a role of even to using spironolactone to decrease the incidence of hypertension. Of course, we don't have enough data to make much claims on this statement at this point. And when they repeated the sensitivity analysis in different subgroups, they yielded the same results. So they have excluded subjects on mineralocorticoid receptor antagonists. They excluded subjects on any kind of antihypertensives, excluded those with a prior history of cardiovascular disease. And even after adjusting for the 24-hour urine sodium and potassium, they had the same outcomes. So how do we screen for primary aldo or a renin-independent aldosteronism? We have three groups of tests. The one on the extreme right is about angiotensin peptides, which is more of which is used mostly in research and not in any routine clinical practice. So our focus is mostly on these two, which is the renin, the estimation of renin and the estimation of aldosterone. So renin can be estimated in two ways: plasma renin activity or PRA, and a direct renin concentration or a DRC. Since we use PRA more commonly at VCU and at many other centers, I'll focus my discussion mostly on the PRA. And what PRA means is it actually estimates the activity of renin. And the activity of renin in the body is to convert angiotensinogen to angiotensin 1. So when we send the plasma sample, it is frozen ASAP, and they look at the rate of formation of angiotensin 1 in the sample, and based on that, we get the lab value for PRA. And the units are nanograms of angiotensin 1, which is generated per ml of plasma in 1 hour. And it can be measured in upright or seated position. For aldosterone, the units are nanograms per deciliter. What we measure, so at VCU, we send the samples to LabCorp, and LabCorp measures the sample using mass spec, means a refrigerated plasma sample, not frozen. And another way to estimate aldosterone is also by using a 24-hour urine aldosterone levels. So the key points when we order a screening for primary aldo is never focus too much on the aldosterone to renin ratio. The thing is, depending on the cutoff that we use for the aldosterone to renin, the sensitivity and specificity vary. If you use a cutoff of 20, at best the test is 80% sensitive and specific. If you increase the cutoff to something like 30, then you increase the specificity, but there is a high chance you will miss a lot of patients with mild primary aldo. The more important thing is to always try and interpret the renin and the aldosterone levels independently. And as I mentioned in the initial slides, we expect to have a suppressed renin in all cases with primary aldosteronism. So our focus should be that if renin is suppressed, how is the plasma aldosterone? Is it appropriate or is it inappropriate? Meaning, is it appropriately suppressed or is it inappropriately normal or high? And the other important point is to understand that in the face of a renin suppression, having any aldosterone in the circulation represents some phenotype of the primary aldosteronism syndrome. And the reason to understand it this way is because these are the groups of people who may be responsive to mineralocorticoid receptor antagonists and who may actually benefit from this drug by preventing the adverse effects of aldosterone on the cardiovascular system. And how do we define renin suppression? Having a PRA level which is less than 1 in seated position, in seated or upright position, or less than 0.6 if it's in a supine position. And if we are checking DRC, then the cutoff is to have it less than 10. The other important piece of information is to look at serum potassium at the same time whenever we screen for renin and aldo, because hypokalemia is known to inhibit aldosterone. And I'll just describe a bit about this. The important thing to understand is if you see a suppressed renin, and if you see that the plasma aldosterone levels is something like 6 or 7, and the corresponding potassium is like 3, then in reality, it's quite possible that the plasma aldosterone level is much more than 6 or 7. It could be even more than 10. The aldo is low only because the potassium is low enough and it is suppressing the aldosterone production from the adrenal cortex. Whereas if you see a plasma aldo of 8 or 9, and if the potassium is normal, and of course, most likely you are dealing with a true aldosterone value and it increases the confidence on the test result. The other important thing to understand is to screen for primary aldo irrespective of the medications that the patient is on. Even if the patient is on mineralocorticoid antagonists, I prefer sending the patients for a primary aldo screen, and irrespective of the time of the day. Yes, there is a diurnal variation in the levels of renin and aldo with higher levels in the morning, but when we are seeing the patient in the clinic, it is much easier and will increase the chance of finding a disease if we screen them randomly. If there is a high clinical suspicion and if we see a false negative result, you always have the option of repeating the screen. But at least because we have started the screening process, we'll start looking into it instead of completely ignoring this entity. So the reason to screen even when the person is on antihypertensives is that most of the antihypertensives work by volume depletion and they cause vasodilatation. So if anything, they increase the renin levels or the PRA. So the net effect is really to have a false negative result with a higher PRA with or without a lower aldo. Beta blockers will decrease the PRA, but they also decrease the aldosterone. So the overall effect on the renin and aldo may not be significant. Mineralocorticoid receptor antagonists, including high dose of amiloride, will raise the PRA and will raise the aldosterone levels. And in fact, if you see a suppressed renin when the patient is on these antihypertensive drugs, which are known to increase the renin levels, then it will actually increase the confidence on the fact that the patient has a true primary aldo. And if the renin is elevated, and the concern is that it may be a false negative because of drugs, you always have the option of repeating the test by holding the mineralocorticoid receptor antagonist for 4 weeks. And if the renin still remains suppressed, you can continue further screening by holding the diuretics and holding the RAS inhibitors as the next steps. But usually, in most of the cases of overt primary aldosteronism, we should see a suppressed renin even when the patient is on mineralocorticoid antagonists, or at least if you hold the mineralocorticoid receptor antagonist, you should be able to see a suppressed renin. It is really those mild forms of primary aldo that we more frequently miss when the patient is on diuretics or on a RAS inhibitors. Unless the patient is on very, very high dose of diuretics and looks volume depleted, the routine diuretic dose that we use for management of hypertension should not have a significant effect in diagnosing patients with overt primary aldo. So to summarize, you need 3 labs for screening. So one is a PRA or a renin. And the first step is to check if the renin suppressed. If it's falsely high, then maybe you're not dealing with an overt primary aldo. Maybe it's mostly the mild to moderate forms of the disease. Then the next step is to check for the serum potassium. Is the serum potassium low or normal? If it's low, this can certainly impair the production of aldosterone and increases the chance that you may be actually dealing with a patient with a more overt primary aldo. And then the plasma aldosterone. How much aldosterone is being made in the setting of a suppressed renin? Higher the aldosterone levels, more likely that you are dealing with an overt PA. And then you always have to, depending on the clinical features and the lab features, we need to gauge the chance of finding a lateralized disease and proceed with next steps. Some of the criteria, and these are not standardized, but as described by experts in this field, there is a higher chance of finding a lateralized disease if someone has hypokalemia, having a plasma aldosterone of more than 25, and if there is evidence of tumor on the CT, a more controlled hypertension, normal adrenals, having an aldosterone of less than 50, the chance of having a lateralized disease is low, but doesn't completely rule out the entity. And one other important aspect is about how the aldosterone is measured and how it was described in all the previous literature. So what we use nowadays is the mass spec. Most of the guidelines were designed based on the immunoassay-based measurement of aldosterone levels. The aldosterone measurements using mass spec have been shown to estimate aldosterone to a much lower level, at least 25 to 87% lower, depending on the study. And this was shown in a study of healthy controls. In a group with overt primary aldo, when they compared these two measures of aldosterone, in at least 25% of them, the plasma aldosterone levels using mass spec were actually less than 10. And when they estimated the plasma aldosterone in supine position at the time of adrenal vein sampling, using mass spec, in at least 25%, the plasma aldosterone levels were less than 5, indicating the chance that whatever plasma aldosterone we measure using mass spec can actually show a much lower. There is a chance of showing a much lower plasma aldosterone concentration when compared to the immunoassay, which is more traditionally described in all the studies. And there's always this variability of plasma aldosterone because of all the parameters which I described in this slide, including the timing of the day, and which brings into question the role of 24-hour urine aldosterone, because there can be variations in plasma aldo. 24-hour urine aldo maybe is a more reliable way of estimating the total aldosterone production in a full day. The only downsides are that not all centers routinely do the 24-hour aldo, and 24-hour aldo measures only the free and the acid labile forms of aldosterone. It doesn't measure some of the metabolites of aldo, which may lead to some underestimation of the total levels. And certainly it is more expensive and needs acidification of the sample, certainly not more widely available. So whom do we screen for primary aldo? We all know about the high-risk populations, anyone with severe or resistant hypertension, any hypokalemia, unexplained or a diuretic-induced, hypertension with adrenal mass, sleep apnea and hypertension, atrial fibrillation and hypertension, and a strong personal or family history of primary aldo. The standard endocrine guidelines don't describe this entity of hypertension with AFib, but the more recent authors have been suggesting to screen this group as well for primary aldo because of the very high association of AFib with increased aldosterone levels. And then there is this small group at the bottom of the table. Some countries like Japan, they routinely screen all the new onset hypertensives for primary aldo. And in fact, in my clinic, I have screened a couple of patients who were referred to me for a new onset hypertension. They were not on any antihypertensives at baseline, and they had a normal volume status on clinical exam. And their renin levels were on the lower side, and their aldo was somewhere in the range of 7 to 8. So nothing overt, but certainly they had a phenotype of a dysregulated aldosterone. And I have started both the patients on spironolactone, and one of them I had to switch to eplerenone for other reasons, but I started them on a mineralocorticoid receptor antagonist. Maybe there is a role of screening at least all the stage 2 hypertensives because they have a more severe degree of hypertension and have a higher prevalence of this dysregulated aldosterone, so higher chance of finding this condition. So before I go to the last slide, where I summarize some of the opinions regarding screening based on one author who is an expert in the field of primary aldo, I would like to just reiterate this point that never categorize aldo as low or high. This is overly simplistic and misleading. There is no actual cutoff to say that this is a low aldo and this is a high aldo. Always, aldosterone production is either physiologically appropriate or physiologically inappropriate. And identifying a high-risk patient with renin suppression, having a PRA of less than 1 in upright position, always assume that it is primary aldo until proven otherwise, because this will increase the chance that more number of these patients will be started on mineralocorticoid receptor antagonists, even if it's a small dose, and to prevent some of the effect of aldo on the cardiovascular system. So this is one graph which was presented in a recent article. And this group is from Harvard, and at Brigham, they kind of routinely do, they follow these steps, and they do adrenal venous sampling for a lot of these patients. And their rationale is that even though there is no obvious adenoma, these aldosterone producing cell clusters might exist more in one adrenal gland than the other side. So they routinely try to do the electrolyzation and record the data. And if the patient agrees, they do proceed with adrenalectomy to remove the site having a higher aldosterone production. Again, this is not part of the standard guidelines, but this is adopted by some centers routinely. So what they do is when they screen high-risk population and they find evidence of suppressed renin, they categorize the next step is to look at the aldosterone and potassium. If the aldosterone is more than 15, they have a more liberal criteria to label them as overt primary aldo. And the reason being all the variability which happens with plasma aldosterone and the difference between the different different lab tests that we do to estimate the plasma aldo. So they have a more liberalized criteria for this. They label them as overt primary aldo. And if the patient agrees, they proceed with localization and the further steps. And if patient doesn't agree, they do start all these patients on empirical mineralocorticoid receptor antagonist therapy. Of course, they repeat the renin and aldo before they proceed to the next steps. If the renin is suppressed and if the aldo stays low, then the chance of having a primary aldo is very unlikely. They make sure that the person is not having hypokalemia, and they rescreen the individual to make sure this is actually a true test. And if it comes back low, they are labeled as a low renin hypertension, but still the person gets started on mineralocorticoid receptor antagonist treatment. If it is 5 to 15, then it is labeled as primary aldo until proven otherwise. They get to do a confirmatory test, and based on the next steps, based on the result, they proceed to the next step. But the point is, almost every time someone is found to have a suppressed renin, they try to prescribe drugs like spironolactone to improve the chances of blood pressure control and to prevent some of the adverse effect of aldosterone on the cardiovascular system. And the other way is to also look at 24-hour aldo whenever we find a suppressed renin. And again, they have a more liberal criteria for this. Instead of 12, they use a cutoff of more than 10. And for the urine sodium, instead of 200, they go with 150. And in fact, when I discussed this with one other physician who is again an expert in the field of primary aldo, he sometimes even uses a urine sodium cutoff of 120 to when he's trying to interpret the results of this confirmation test. And based on the urine aldo levels, they either proceed to the next step of lateralization, or they start the patient on this mineralocorticoid receptor antagonist. So just to complete our case, so this is this 55-year-old male who is on 3 drugs, having this history of uncontrolled hypertension and hypokalemia. So when he was screened for primary aldo, his PRA was low at less than 0.6, and the plasma aldo was like 5.2, with a ratio of more than 9. So this screen was deemed as negative, and a repeat screen was done after 5 months when he was admitted with a hypertensive emergency and hypokalemia. His PRA was 0.6 and plasma aldo was slightly high at 9.5. So this was deemed to be a positive screen. Primary aldo was confirmed with an oral salt loading test with a 24-hour urine aldo of 15. CT abdomen showed this bilateral adrenal hyperplasia with no adenoma. Patient declined adrenal vein sampling, so he was started on spironolactone at 75 milligram daily. His potassium improved, and subsequently his blood pressures remained well controlled. So the take-home points are screen, and screen for primary aldo. It increases the chance of finding more patients, and maybe more patients can actually benefit being on a spironolactone or eplerenone, depending on how much they tolerate. Thank you so much. I'm happy to take any questions.
Thanks, Dr. Sri, for a very great talk. We do have a couple questions from our fellows. While everyone else, if you want, please put the questions in the chat, and we can get those questions answered. So the first question we have is there any difference in cardiovascular morbidity and mortality when comparing primary and secondary hyperaldosteronism?
So yes, I didn't include that study, but there is, I don't recall the exact details, but certainly there is evidence to show that primary aldo has a much worse effect on the cardiovascular system when compared to secondary aldo. But again, this has to be looked into the context of what's causing the secondary aldo. In the sense, if it's more from something like a hypovolemia, we don't see so much of a change. But obviously, if it's happening in the setting of an underlying cardiac disease, it may be hard to estimate the true effect of aldo and to compare between primary and secondary in that scenario. Because there you have a primary cardiac problem, which is stimulating your aldosterone. So hard to differentiate this effect in that particular subgroup. But certainly the aldo, which happens because of other reasons like hypovolemia or hyperkalemia, it certainly won't have any adverse cardiovascular outcomes.
All right. And our second question is there any echo changes that would point you towards primary versus secondary hyperaldosteronism?
The only literature which I read was more about if in a particular subject, if you see that the degree of left ventricular hypertrophy and the cardiac changes are disproportionate to their clinical picture, then it may be a reason to screen for primary aldo. I don't recall the exact details about the cutoffs, what they used, but if the echocardiographic changes look disproportionate, and if you don't have, I mean, if you're not able to explain this based on the clinical picture, it might be a reason to screen for this condition.
Great, thank you. I know we're a few minutes early and I don't have any more questions in the chat or from our fellows this morning. I wanted to thank you very, very much. Great talk.
Kelly, can I ask one?
Oh, yes, Dr. Shah, have at it.
So this is more a question on MRA mineralocorticoid antagonist, and they're essentially recommended now across the spectrum of ejection fraction for heart failure. And there's the biggest hesitancy I see in clinical practice is people are worried about the underlying renal function and or potassium homeostasis. Can you tell us from a nephrologist perspective, what EGFR do you become wary of starting an MRA? And then also, are you starting to use MRAs routinely in dialysis patients?
So, yeah, it's a great question. Thank you, Dr. Shah. So I don't really have any cutoff in my mind. Yes, if you look at standard guidelines, once EGFR is, well, not standard guidelines, but most of the literature, the EGFR is less than 30, they don't recommend starting patients on mineralocorticoid receptor antagonists. But really the risk is more about hyperkalemia. I have patients in my clinic with CKD where I have seen, because of their prior history, I did screen them for primary aldo. I totally know that screening for aldo is not very standardized in patients with CKD, but they did have a low renin, but more importantly, they had a high aldo, which is otherwise, there is no reason for them to have a high aldo level. So I did start them on low dose spironolactone. I usually go with like 12.5 milligrams when I'm starting, and there won't be much room to increase the aldo because, increase the dose of spironolactone because of the chance of hyperkalemia, and that these patients are usually also on the RAS inhibitors, which increase the risk for hyperkalemia, and certainly not with lower GFRs. But starting them on a low dose is certainly not a bad option. And if the EGFR is low and if the potassium in all the previous labs is very steady, say like below 4.5, you can even start them on spironolactone if indicated, say like at 12.5 milligrams 3 times a week, because the T half of spironolactone actually goes up significantly as the EGFR goes down. So even with such a small dose, they still have some amount of the drug floating in the system and will offer some benefit. Of course, I kind of explained to the patients very clearly that there is a risk of hyperkalemia, and I ask them to watch for potassium foods, and I make sure I monitor the potassium and creatinine after 4 weeks to make sure that it is steady. And for the second part about dialysis, so there is one study where they have looked at using 25 milligrams of spironolactone in dialysis patients. The only downside is like, again, the risk of hyperkalemia. You might think that the patient is anuric, but spironolactone also blocks the potassium excretion, which happens across the colonic epithelial cells. So there is a risk of hyperkalemia. But if you have a patient who is compliant, and again, whose potassiums and all the previous readings have been very steady, it is reasonable to start them. But only thing is, need to make sure that the patient understands the risk, and we recheck the potassium in a certain time frame to ensure we are not causing any harm to the patient.
One last question, sorry. Where does the role, or how would you describe to a group of people who don't use this drug very much, where's the role for finerenone compared to the other MRAs, to spironolactone and eplerenone? Is there a true physiologic difference, or is this is the finerenone data just a study in a contemporary era for same class?
Theoretically speaking, there is a benefit. I mean, because it acts in a similar way with relatively less side effects and not. But in terms of data or evidence that we have right now, it is confined to patients with proteinuric CKD or with heart failure in the setting of type 2 diabetes. I'm not using finerenone in these patients because there is no evidence and like hard to get the approvals and all. But certainly, I mean, like from a theory standpoint, I think it will have the same amount of benefit that spironolactone is having, except we need to have more evidence to keep doing this on a routine basis.
We also have a question of, is there a number that our providers can call for the VCU hypertension clinic? Or
Yeah,
how to
so
get them in with y'all?
yeah, so in the nephrology website, we do have a link for hypertension, and it does have the number for the clinic appointments.
Great. Well, again, thank you so much.
One last point which I would like to mention, and I didn't get a chance to cover in the slides because of time, is when we are managing patients with primary aldo, certainly starting them on spironolactone is a great step to begin with. But one thing which studies have consistently shown is how to, like the best way to monitor these patients is by rechecking the plasma renin activity. Because when they have looked at patients with primary aldo who had a surgery or who are on medical treatment, they initially saw that the benefit of surgery was far more than the benefit of being on spironolactone. But when they subdivided the group on spironolactone based on their post-treatment plasma renin activity, one thing they have shown is if the renin activity gets unsuppressed by giving a sufficient dose of spironolactone, meaning like if you keep the level at least 1 or more, versus if the level continues to stay below 1 even after being on spironolactone, the adverse outcomes are much higher in the group with a PRA of less than 1 post-treatment, meaning that you need to do sufficient mineralocorticoid receptor blockade and make sure that you give the patient a higher dose. Even for the same level of blood pressure control, those who are at a higher dose of spironolactone and those who have their PRA at least at 1 or more have significantly better outcomes when compared to the other group.
Awesome. If there's any other questions, we can definitely get them over to Dr. Sri. And thank you so much for all of your time this morning. We are very appreciative and we look forward to working alongside you.
Yeah, thank you so much.
Have a great day, everyone.
Yeah, you too.